All right, this will be the last conversation or the last presentation for the day, but I hope it's not the last of the conversations today. And by the way, we have not talked about the people who are out there in cyberspace, but I do want to point out that after looking at the screen, it is clear that the video adds 10 years and 15 pounds to all of the speakers. So just want to make sure you at home know that. The next talk we're going to have really does wrap up the day very nicely, and it's a conversation about the importance of the three-part aim, which is a nice unifying way to talk about what it is that we need to do in the United States system, and then the support that Health IT gives to that. Please. And the person who's going to lead this is Judy Murphy. And if you know Judy, there's only 2 degrees of separation between Judy and anybody else in this industry. She had served on the Health Information Technology Standards Council. She's been doing this work for 25 years. I don't know anybody who's more enthusiastic about the work that she does. She has responsibility for the programs and the policy, which is a significant amount of work. And when I talk about Judy, I usually mention certain elements. There's earth, wind, fire, water, and Judy. She is a force of nature, so I'd ask her to come up and finish out the day. Thank you.
Well, good afternoon. I'm lucky enough to be able to lead this last, and I will assert to all of you it's actually the best part of the day, where we actually take all this health information technology stuff that we've been doing and bring it into real practical use. Several times during the day it's been mentioned, health information technology is the means to an end, not an end unto itself. I know that I'm dealing with a lot of folks who have done implementation out there. I myself, before coming to ONC a year ago, had done implementation for 25 years, started when I was 3 or 4. It's hard. And what happens as a result of it being so hard is that you get to the end of it and you actually think you're sort of done. You know, like feels pretty good because you got it in. But I think you all know getting it in is like maybe the end of the beginning, but it is certainly not even the beginning of the end. And so the idea that we have to take the systems that we install and care and feed them and optimize them if we're actually going to drive the kinds of changes that we're talking about with healthcare transformation. And that's what we're here to talk about is healthcare transformation in this last session of the day. Now remember, Farzad set out a couple of assertions early this morning, and I wrote them down because he's my boss and I'm a smart person. Do what your boss tells you. In truth, though, they were really, really good things. We believe that healthcare can be better. We believe in the power of information, and we believe in the power of health information technology to improve care. And that's what we're really here to talk about, some very practical examples of folks who have done that, who have taken health information technology and made a difference in the way they deliver care and the way they pay for care in their settings, their organizations. So let me introduce our 3 panelists here, and we're going to start with your left, my right, in terms of a small presentation. They're going to give a little bit of background and talk about this whole idea of the 3-part aim. And by the way, just to remind everybody, better health care, better health, and lower cost. And those 3 items are also what comprise our national quality strategy, and so they're really important when we think about keeping in mind why we're doing what we're doing. And we'll ask each one of them to address that from their setting. And then again, we're going to open it up, just like we have in some of the other sessions, for Q&A. What's going to be different is I'm not going to ask any questions. They're going to ask questions of each other, and I'm going to give you all the time in the Q&A session to queue up at those microphones and ask your questions as related to your own experiences and what you're interested in hearing about. Okay, so let me start the introductions. Dr. David Wennberg is CEO of the Northern New England Accountable Care Collaborative, formed by Dartmouth Hitchcock, Fletcher Allen Healthcare, Eastern Maine Healthcare Systems, and Maine Health. The collaborative creates common financing and accountable models and provides a common infrastructure to support the delivery of value-based accountable care. Dr. Wennberg also serves as the chief scientist at the High Value Health Collaborative at Dartmouth Institute. Prior to his work here, Dr. Wennberg co-founded Health Dialogue Analytics Solutions and served as their chief science officer. Dr. Wennberg received his medical degree from McGill University and his master's in public health from the Harvard School of Public Health. He is an internationally recognized authority on the root causes of unwarranted variation. His work has been published in many peer-reviewed medical journals. Our next presenter and panelist is Dr. Karen DeSalvo. Dr. DeSalvo is Health Commissioner for the City of New Orleans and serves as Senior Health Policy Advisor to Mayor Mitch Landrieu. She directs the Health Department, whose mission is to protect and promote the health of New Orleanians. Okay, that was hard to say. New Orleanians? Did I say that right?
That's pretty good,
huh? Okay, and also serves Mayor Landrieu on local, state, and federal health policy matters. She has undertaken a major effort to transform and modernize the City Health Department into one that is more efficient and capable of improving the public's health. Dr. DeSalvo brought to the role more than 20 years of experience in medical practice, research, and policy aimed at improving access to quality, affordable community health for all. She envisioned and led the effort to create the innovative and nationally recognized model of neighborhood-based medical homes for low-income, uninsured, and other vulnerable populations in New Orleans following Hurricane Katrina. She has successfully convened stakeholders at each level of government to move innovative healthcare coverage programs forward in Louisiana. She received her medical doctorate and master's in public health at Tulane University, a master's in clinical epidemiology from the Harvard School of Public Health, and her bachelor's from Suffolk University. And our third and final panelist is George Halvorson. He's chairman and CEO of Kaiser Permanente, headquartered in Oakland, California. Kaiser is the nation's largest nonprofit health plan and hospital system, serving more than 9 million members and generating nearly $50 billion in annual revenue. George Halvorson has won several awards for his commitment to health IT and for his leadership and achievement in advancing healthcare quality. The development, implementation, and maintenance of Kaiser Permanente's information technology infrastructure represented a multi-billion-dollar strategic investment that provides comprehensive care coordination and continually improving quality of care and service to its members. He is the author of 5 comprehensive books on the U.S. healthcare system, including his most recent one, Healthcare Will Not Reform Itself, a user's guide to refocusing and reforming American healthcare. Prior to joining Kaiser, Mr. Halvorson was president and CEO of Health Partners, which is headquartered in Minneapolis, for nearly 18 years. Please join me in welcoming our 3 panelists. Okay, so let me start. Do you want to do some introductory remarks?
Sure, thank you, Judy. And this is a world of very small separation. I don't know if it's 2 degrees always, but so I have known George for quite a while because in my previous job, Kaiser was one of our clients. And my one anecdote I'll tell, which is appropriate for this audience, is one time I was going to Kaiser in Oakland, and I got into the cab, and we were driving the cab, and the cab driver leaned over to me and he said, "You must work for Epic." And I said, "Oh, why would I work for Epic?" He said, "Well, because we just keep taking people up there and back there and all the time." But it's great. Yep. And then Karen and I actually had honor of working. I had the honor of working with Karen after Katrina, and have known. And she's a dynamo. So for me, it's very humbling to be on this panel. So the Northern New England Accountable Care Collaborative is a new entity. It was just started, officially started in March. We've been working at it for about 18 months since after the Affordable Care Act had been passed, but before any of the ACO regulations had been written. And it was started as many of these sort of collaboratives have started in a very grassroots way. I happen to know 2 of the CEOs of the healthcare systems in Northern New England, and then directly and through reputation, the other 2 entities. And we had CEOs, and we had talked, and I've been individually talking with them about getting ready for for accountable care, whatever it was going to be like. And I had the benefit of being in Northern New England, where the relative patterns of care are quite conservative, and so they had been looking for new opportunities to move away from the fee-for-service environment. And so these 4 streams had been going on between the 4 systems and actually Dartmouth College, which is the other entity that's part of our group. And I got tired of both driving across northern New England and secondly talking about the same thing. And I said, look, you guys are all talking about the same thing. I have this sort of crazy idea that instead of each of you building your own infrastructure to support accountable care, what if you came together? And the reason we were successful in bringing those groups together are two things. One is they were only moderately competitive. They were more cooperative in terms of how they delivered care across the state. But they also had this understanding that if they did things together, it would accomplish two things. One is it would probably lower the cost of ownership of building the infrastructure. But more importantly, and I think this is the other part that's a really interesting aspect of the technology, is that if they did things together and actually learned from each other, they would actually accelerate their movement into this new world in a way, and it's sort of, this is the underlying underpinnings of our group, is that technology is necessary, but it's clearly not sufficient to get to where we need to get to. So what are we? We're really a product and a services entity. We are a shared services organization that support these four entities as they're moving into accountable care, and actually will be supporting many more as we grow. And our mission, and I didn't ask to be on this panel for the mission, I don't think, or it wasn't asked to be on the mission, but it actually is to deliver products and services to support providers as they migrate from fee-for-service, production-oriented care into care that's paid for by capitation and global budgets, while delivering efficient and high-quality care aligned with the triple aim. So the triple aim is actually the ending of our mission statement. The products that we're developing is really an integrated information system. We take data from a whole variety of sources, from Epic, Cerner and Centricity, from a whole variety of core lab entities, including Quest and LabCorp. We get information from their local HIE. We get ADT information as well as lab data from that entity. And we haven't started yet, but we'll be getting patient-reported measures in the second quarter of next year. And we also get claims data. The data is integrated into a patient-centric longitudinal record, and it becomes the sole source of truth for the applications that sit on top of that. And as we all know, there's no such thing as truth in healthcare data, but there is an agreed-upon standard that we can have in terms of what we agree to call truth. And what we're trying to do by having a single source of truth, essentially, is to keep everybody on the same page from an information standpoint so that we can argue about the care we deliver, but not about the data and how it's aggregated and organized. Once the data are in, we do a whole variety of predictive models and triggers and alerts and create essentially a population health management information system, or as we call it, population health management, one person at a time. And on top of that are portal web-based applications for care coordinators, for physicians, and for administrators who are looking for the contract performance, if you will. And again, all built onto the same information technology. We've tried to do some things which are a little bit difficult in terms of having the full nuanced value of a data warehouse with near real-time information. And the way we've done that is really through our selective and practical applications of real-time data. And a perfect example of that is our connections with the Health InfoNet, which is the HIE in Maine. We get HL7 ADT messages from them essentially in near real time. And those ADT messages are parsed into the critical aspects that we think for managing populations, which are transition registrations from emergency room, ER, freestanding facilities. And that data bypasses the EMR and shows up immediately in the application of the physicians and the care coordinator. So they actually know, not tomorrow, but within minutes, that somebody has been discharged from an emergency room, as an example. The application suite we started building in July, and our first application is rolled out, the care coordinator application, on Monday, so this is going to be a long weekend. The physician application is the next, and then the administrator application is the third. We've done something which is a little bit tricky from those of you in the vendor world out there, which is our investors, founders, owners are also our clients, and that is always a double-edged sword, but they're actually building the product. We're building the product with them and for them. So that's actually been very fun for me to do that. And our aggressive timeline is to have the last two applications out before July 1st. And the reason we're actually able to do that is we've taken, again, a very practical approach, which is we don't want to have it perfect. We'd rather get it out, used, feedback, and then iteratively build that on top of that. Our goal from an information standpoint is to have not just a regional population-based, using it, systems, hospitals, and healthcare providers, but actually reach out across the country. And our goal there is that we have a very intensive benchmarking data in terms of best practices along the triple aim, and the more systems that are involved with that and the more variation, which there's tons of variation, is there, can inform us as we move forward. I'll stop with the technology and then add the last piece before I turn it over to Karen, which is we're also realize that the information is necessary, as I said before, but insufficient. So we actually have collaborations around the technology, and we're trying to create a word that in my old age is hard for me to say, but I'm getting used to it, an ecosystem, if you will, of users of the information. And so our first one is the new care models. So each of these organizations are either pioneer ACOs or shared saving program, MSSP ACOs. 3 of the 4 already have commercial ACO contracts, which I didn't talk before, but we're actually having Medicare data as well as Medicaid data and the commercial data all into the same information system. And our first model is the new care model. They all have patient-centered medical homes, but as you know, a patient-centered medical home varies dramatically from area to area. And we're starting to get enough data now that we can actually see insights from the way they've constructed their patient medical home in terms of how they are doing in terms of getting patients actively involved in shared decision-making, improving the care, and reducing the cost. And that ecosystem, if you will, of data feedback not only is great for product improvement standpoint, but it's really going to be the critical aspect for what we're trying to accomplish here in the end, which is really care associated with the triple aims. I could go on, but I won't.
We'll give you some more time later.
That was perfectly 10 minutes. That's impressive.
Thank you. I wasn't even watching the clock.
So David was a knight on a white horse and came down to Louisiana when we were still in a debris field to help us rethink how we would build our healthcare system in a better frame, and I'm going to get to that. But first I want to also publicly thank Kaiser Permanente, because not only immediately after the storm, but consistently year after year, your employees volunteer to come to the Gulf Coast and help our communities continue to rebuild. So we really appreciate that spirit of volunteerism, and it's always joyous for them. You can tell that they really love it, so we appreciate all that.
They love it.
Too. So the story that I want to share with you is about the transformation of our health care culture towards reform, and how IT has fit into that, and talk a bit about how the triple aim mirrors it and where we're going. For us, really, health is the place we are right now with the triple aim. We're beginning to think about how IT informs it. For Louisiana, we have unfortunately been consistently at the bottom of the pile with respect to care indicators, high costs, poor quality, irrespective of payer, and unfortunately have a black box of some 20% of our population for whom we really don't know anything about the kinds of care that they're receiving or the cost of that care. That's our uninsured population. And for adults in that age window of 19 to 64, it's upwards of a third of the population. And that is unlikely to change in the near future, but we have found some good end arounds that help us understand. What we did do is we said, given that the floodwaters of Hurricane Katrina closed all of our hospitals essentially, and created an opportunity for us to work together in a different way, what would we build? And we pulled together key stakeholders, be it hospital association, physicians, nurses, nursing homes, legislature, academics, and ragtag other people like myself, and created a charter with a set of values and a goal that called for everyone to have access to an affordable health insurance product, to use health information technology to improve care, to found the new system on primary care and prevention, and to create a culture of quality in a place where we could sit and talk about quality. So it was really 4 big items for us. Statewide, we've had a lovely resurgence of primary care, and even though in the United Health Foundation rankings yesterday we came out poorly again, one of the better indicators we have is in primary care. In Orleans Parish, for example, we're now in the top 10% nationally in primary care providers per capita, and that is a deliberate policy action taken on after the storm to create a great work environment for primary care, use incentives to recruit and retain providers. And the great environment really was not only the medical home, but the opportunity to use data to make decisions at a population level. So that was having electronic health records. In creating the primary care infrastructure, Louisiana, in particular New Orleans area, is a place that had relied on the public hospital system for generations. And so we did not have a network of neighborhood-based primary care for the insured or uninsured. This was something we all endeavored to build. We have done so successfully. Now 20% of the greater New Orleans population uses one of the medical homes in some 100 points of care that range from federally qualified health centers that offer robust services from dental and mental health and specialty care to school-based health centers, and still just a few mobile units hanging on in some of our harder hit areas like some of the lower parishes. That means that now the uninsured in particular have access to great quality care, which we know because they're NCQA recognized and or are a part of a network that uses quality-based care and are part of a collaborative that has formed, which I'll get to a little bit later. But we are now, it's not just there's care, but it's good care. And so we have been able to define that as a state and as a community, that this is what we should expect for our population. The quality piece was that we decided we wanted to create a safe place where data could be shared and conversations could be had about healthcare quality. We established the Louisiana Healthcare Quality Forum, which carried forward a lot of this blueprint in the 4 areas and continues to this day. The forum became the recipient of a multi-payer database that Health Dialogue helped us to create. It has now undergone an additional iteration and is ready for analytics. I have to tell you, after all these many years, we're finally getting there. And has been the leader for 2 of our ONC grants, the Health Information Exchange, which has been a successful statewide endeavor that has touched the majority of the parishes, the counties in the state, and has enrolled over 40 hospitals already, and nursing and ambulances and home health agencies thinking about linking together a broader system of care. Is the Regional Extension Center grantee, has been successful in that, exceeding our goal of enrolling providers, primary care and also now specialty care, as well as helping people to achieve meaningful use, to the Congressman's point earlier. The third area that we wanted to look at was health information technology and how that would enable better care, not just at the point of care, but really thinking at the population level. So for us, this means that when we had this experience that the city flooded and we were shut down for 30 days under mandatory evacuation, and people were scattered all across the nation. I suspect people in this room sheltered and took care of people. Those folks left with out pieces of paper describing their medications. It was a very unsafe situation, particularly for people on chemotherapy regimens or on anticoagulants. And so there was a very acute sense for doctors in the community as well as the systems that we needed to fix that, because in times of disaster, we needed to be more prepared to help people maintain their care, whether that was for HIV or TB or chemotherapy for cancer. We also needed to do a better job every day. And the fact that we were building from the ground up, especially the primary care infrastructure, was a tremendous opportunity. We had no legacy systems to move out of. We started, by and large, from scratch in electronic health records. And many providers, I've seen some of them, are here in the community. They can tell you they've already been through a second iteration, stepping up to a more sophisticated software system, because they realized that they wanted to be able to do more for their patients than what the original systems, or they've gotten the system to modify. And we've moved in a direction of having the majority of the providers, and i.e. the patients in this community in New Orleans area, have access to their health information on an electronic health record that is not only a relational database but web-based, and that means if they have to evacuate, et cetera, we can find that information for those patients, and that's always important. But it also means that we're able to do a lot more with respect to population management in the clinics. This is so critical when you have limited resources and you want to know exactly, try to understand who you're taking care of and are you doing a good enough job. I want to get back into that when I get into payment in the last part of the system. But before I get away from HIT, I want to tell you cultural success and then a real success. To the Congressman's point about doctors not wanting to move into health information technology, I say all that like we just implemented electronic health records and now we have an exchange as though it was just easy as pie. And of course it wasn't, but it was easier than I think you could imagine for a variety of reasons. However, one of the memories that I'll always hold is that our state medical society when they had to sign the charter indicating all the things that we believed in for our future of healthcare in Louisiana, was that they needed to change the policy in the State Medical Society's manual that said they opposed the use of computers in medicine. This was the spring of 2006, and they were so excited to be a part of this movement and to know now what they did. And even though they were cranky about the challenges, they have really been a champion in our state, the physicians as well as many other organizations, to understand how important this is for quality and safety and for cost reduction. So that is an example of how we have really made institutional change. We are a recipient of a third ONC grant, which is a Beacon, Crescent City Beacon Community Grant, part of the Beacon program. And that has been a chance for us to take all of the pieces we had, the great primary care, electronic health records, this increasing culture of quality, and put that together in an effort that linked with hospitals and somewhat specialty care and got us to focus on population-level indicators and turn our attention towards cardiovascular disease and diabetes, something David encouraged me to do 7 years ago, but it was pretty hard to herd the cats. And the Louisiana Public Health Institute, who's the fiduciary agent, has done a great job of pulling together community members to get everyone to agree on a set of standards, define what we mean when we say our population, define diabetes. Y'all know all this better than I. But it has been a tremendous exercise to get us all really focused on what matters with respect to the population's health. And now the information is live, going into an information exchange for our community. I believe there's 170,000 lives in there right now. And there's notification for ER visits. It's a really tremendous additional tool for providers and for the clinics to be able to understand how they can do a better job of improving care. The last piece is about the cost of care. And, well, not the last piece. I have one more, and then I'll be quick. Cost of care is something we have been experimenting with in Louisiana. I mentioned that we talked about having access to affordable health insurance for everyone as part of our charter. We haven't achieved that, but we have worked on some end arounds to create a financing mechanism at a minimum for the primary care portion of what we have done that has strung together. And in so doing, for the New Orleans area, have learned that population-based capitation is a great way to pay for primary care. It encouraged the development of teams and a very forward-thinking approach to people's health. It encouraged the providers to work together. Even though they were competing, they were also thinking that they were stronger together. We are now under an 1115 waiver, which is different than the original grant we had. We've modified that with the help of the state and CMS into a place that will fit in Medicaid. It's not exactly where we want it to be with respect to population management, but what we are able to do, which we could not do under the last grant, is actually use the data of Beacon to understand who we care for, what are our quality indicators, and how are we showing improvement in that, so that the bonus system isn't just about structural, oh, you're a medical home, it's actually you're making improvements in the population's health. So it's a great step forward for those providers. Where some of them see that going is creating an ACO-type model so they can use that information for value-based contracting as the state moves forward. I want to say a word about health because I'm the health commissioner, and I think about it every day, and, which is my job. So it's a really public health has a paucity of actionable data. So the information that I work from is often 2, 3, 4 years old. And it's very difficult for me to know if there are hot spots where there's asthma, that maybe there's a housing issue that I could work with our housing authority on, or where people who have mobility challenges live that might need additional assistance in an emergency like a flood or a power outage. And so for one of the many opportunities I see with what we have built as a foundation from the data is to have access to that for public policy decision-making, for making policy, but also for really helping the community in a crisis situation like disaster. We just had Isaac in advance of what happened to the East Coast with Sandy, and the experiences were similar with respect to the power outage and the challenge for some of the elderly and those who were immobile. And I think that having data that is more real-time and claims data is a tremendous opportunity within Beacon, because it's clinical, right? It's not as stale. What we're looking at in New Orleans now, though, is thinking about health as having all the social determinants. Yeah. How can we understand who's not using the system? Who else is in my community? How do I find them and get their information also into that multi-payer database, payer being a much looser idea than just who's using the clinics in the system. So we have gone from 0 to 100, but we know that we have a long way to go. We have a lot to do to understand about our cost equation and how we pay for it better, but I think I'm really proud of the progress that we've made. Thank you.
Thank you. George?
Very impressive. Couple comments about Kaiser Permanente. We are blessed with being a vertically integrated care system, and we have 9 million members. So we have hospitals, clinics, pharmacies, labs, the entire infrastructure of care within Kaiser Permanente, and we take care of an entire population, and we do it for prepayment, which means we're not fee-driven. We don't have to do pieces of care and bill for pieces of care. We get a cash flow from the members, and with that cash flow, we deliver care, and we apportion care inside our organization. And it's a macro model, and until relatively recently, when we were forced to do it for external reasons, we didn't even have a price internally for something like a CT scan or an MRI, because there was no internal structure that involved pricing anything. Everything is based on costs and budgets and appropriate care. So we have this vertically integrated system, a population we're accountable for, and we concluded quite a while ago that the very best way of taking advantage of that organizational model and taking care of that population would be to have sufficient data about the people that we're taking care of so that we knew what the care needs were. We could track care, follow care, track outcomes. And so we decided to go electronic, and we made a commitment to have zero paper inside Kaiser Permanente. We wanted to have paperless clinics, paperless hospitals, pharmacies. We wanted all of our imaging to flow electronically, so we wanted to be filmless imaging. And we set that model up and have been working on it, and we have pretty much achieved that model. We are basically a paperless care system, and our goal is to have all of the information about all of the patients available all of the time to caregivers at the point of care. So we set that as a goal, all as an agenda, and then designed our rollout of our care systems and our systems around that. And it's actually a really good model. It works incredibly well. We've managed to follow up on patient care, focus on patient care. We've cut the death rate for stroke by 40%. We've cut the number of broken bones by a third. Our HIV patient death rate is half the national average. We've got one of the lowest death rates for HIV patients, because we put together a total package of care, follow-up care, care plans, track the patients, communicate with the patients, and we put together an agenda that uses the data in systematic, targeted ways to follow up on care. We just put a new system in place that goes into the database and identifies, we call it the outpatient safety net. And the outpatient safety net scans through the database to identify whether or not there were pieces of care that maybe we should have delivered, or reminders that we should have sent out, or patients not refilling prescriptions that they should have refilled, and created a scan and identified last year across the care system actually 2 million opportunities to do interventions, to send a notice out, or to invite somebody in for an appointment, or to do some kind of a follow-up care. And we can do that because we have the database and because we have the cash flow model we have. And when we do something like cut the number of broken bones by a third, it doesn't hurt us financially because we're prepaid and we're not based on those admissions. So that actually saves us about $250 million a year in hospital admissions that we don't have because we don't have the broken bones. And for just about anybody else on the planet, that would be lost revenue. And so it's a good model. We strongly recommend it, and we believe that we believe to a passion in meaningful use. We really think that if you put data on a computer and then don't use it in a meaningful way, that's a waste of money. But if you put data on a computer and then actually use it in a meaningful way, that's an incredibly powerful and important thing to do in patient care, is better as a result of that. So that's one comment. The second comment I'd like to make is, as we look into the future, what we believe to be true is that the future is going to have care delivered on 4 care sites. And the 4 care sites, the first care site is going to be hospitals, hospital equivalents, nursing homes, but places where patients are in a bed and are taken care of over time. And in that setting, we need the very best and the very safest care. We need the lowest infection rates, the best data flow. We need those patients to be taken care of. And we think that inpatient setting is going to be equipped with increasingly good electronic technical equipment, that the inpatient setting is going to get better and better relative to monitoring, tracking, follow-up. So we think that's going to be an improving care site. We think the second site of care is going to be face-to-face encounters with the patient and the care system in places where the patient actually goes somewhere to get to the care site, a clinic, a medical office, and we think there's going to be a distribution, and we think that's going to go to 2 extremes. One extreme is going to be the mega clinic, the macro clinic, where everything exists. The patients go there and they have one site delivers all care, and we're building some of those, and we're very happy with them. And the other end of the continuum, face-to-face care, is going to be the care kiosk. It's going to be the little outpost, the place that sits in the pharmacy or sits in some other care settings or sits in a school or a work site where the patient goes in, has an encounter with maybe a nurse who is connected in an ideal setting upstream with a complete infrastructure of care. So all the intelligentsia of care is upstream and connected to the patient through that care site. But that care site is going to be very important for a certain number of patients. So we think that's going to be the second site of care. And again, that's going to be is increasingly supported by really great technology, computer technology that's getting better every day. Third site of care, and we think this is going to be equally important, is going to be the home. There's a certain number of patients who really need care in their home, will benefit from care in their home. And if we deliver in-home care with the right technology, the right support, the right interaction, the right communications, the right follow-up, we think in-home care is going to replace both of the first 2 sites of care for many patients. The care is going to be better for those people. It's going to be more proactive. It's going to be, the interventions are going to be good. And the ability right now in the home to have a face-to-face electronic encounter with your doctor or your nurse is getting better every day. And that whole world of having the home be a site of care, I just heard about, this one isn't us, but I just heard about someone who's bringing basically little trailer houses into people's backyards, and they call them something like grandma. Have you heard of this?
Yes.
What do they call grandma sites or something? But they're basically bringing them to people's homes and hooking them up. So it's a little living quarters, but it's got great technology. So it's you're doing the blood pressure and you're doing the EKGs and you're doing all of that out of this site, which is saving a lot of money on nursing home care and in-home care. But the future of in-home care, we think, is very, very robust, and it's going to be well equipped. And then the fourth side of care, we believe, is going to be the internet. And the internet is going to make the world flat for much care. It's going to be people will be able to get diagnoses over the internet, follow-up care, monitoring of their care, tracking of their care plans, care strategies, second opinions. There's going to be a very rich set of apps that are internet-based apps that will help people. And interestingly, that fourth site of care is going to be a place where a lot of the population interventions are going to take place, where people are reminded about decisions they've made to be active, or reminded about decisions they've made to eat well. And that's a place for coaching and nurturing and even some serious counseling, patient-specific. And the fourth site of care is going to be operating at one level, it's going to be very patient-specific, where it's part of an overall care team, and another level where it's completely disintermediating the rest of the care system because it's available as a one-site, very cheap way to purchase particular pieces of care in a way that's much less expensive than it is in other sites. So as we look into the future, we actually believe that the future of care is going to be supported by technology in all four sites of care, and that if we do this really well, care will be less expensive, more consistent, and better, significantly more convenient and that the care outcomes are going to be better. So we're really optimistic about the future of care, and everything that we're seeing from computerizing the pieces of care and the sites of care that we're working with causes us to feel like this is the right path, this is the right direction, and we need to make sure we get this right. Because there's really no, and I'll end with that, there really is no good alternative to re-engineering care. You've got two R words at play. You can either ration care, and there are people that believe that this country should end up rationing care, and I think that would be just criminal. And there's the opportunity to re-engineer care, make it more affordable. And if we re-engineer care appropriately, we can make it more affordable, and the rationing question never needs to come up. And so the path that we need to go down, and we need to do it across the country, is the path of re-engineering care. So I'll end with that.
Well, I'm liking the trailer idea because I live here in D.C. and my husband and I share 700 square feet. And he doesn't need any care, but I like that trailer. For him, not for me.
Husband trailer.
Yeah, you know.
That could work.
So let's go ahead and cue everybody up at the microphones. I'm sure you've got just all sorts of questions. Anybody want to start? I can barely see the microphones. Is this like the end of day sort of lull thing?
Who drank coffee?
Yeah. Over here. Okay, good. Thank you.
Hi. We actually asked this question on Twitter Space as well. For Kaiser Permanente CEO, George, if the Kaiser model is so successful, why is it not being deployed in many states? Apparently, Kaiser plans are only allowed in a few states in the union right now. Thanks.
Not allowed.
I would say loud might be the wrong term.
Just don't go to Georgia. No.
Right. There are basically 2.8 trillion reasons why Kaiser Permanente is not all over the country, and that is the current model of care does extremely well as a business model for the people who are practicing in that model of care. And the hospitals have rich cash flow. Care providers in this country make more money than care providers in any other country. The pharmacy industry makes more money. Medical technology makes more money. So the business model of care works extremely well for the business units of care. And so Kaiser Permanente is a different model, but there hasn't been a perceived need for the model in most of the country because the current model works so well that the status quo has great political power and great market power. And I think what's true of the future is that people will be looking at the things we're doing, the things we're achieving, and basically saying, we can't afford that old model that got us to 2.7, 2.8 trillion, and we now need to look at alternative models. And I think there's going to be a lot, I know for a fact, the ACOs are basically modeled after us. The medical homes are sort of modeled after our care coordination. I mean, the country is evolving to look like us out of necessity. So that's the first part of the issue. And the second answer is, we're not for profit. And we have absolutely no stockholders, which means if you're a for-profit company, you have to grow to stay in business. And if you're the CEO of a for-profit company, you're required by law to maximize your shareholders' value. I'm the CEO of a not-for-profit company, and I have a mission accountability to maximize the care for the people that we cover. But I don't have any financial reason or market pressure to grow. So we don't need to go to the next state. There's no reason. California's huge. Colorado's a great state. We're in some Hawaii is a lovely, lovely place. We're in good places, and we're doing well in the good places. So we haven't had a reason, market pressure to expand, and the rest of healthcare has had a rich enough cash flow that there's been no reason to transplant the model in until now.
And I think also if you look at, I mean, this is pre-George also. Kaiser tried to spread quite aggressively in the old model, and there was a huge culture clash, I think, mission clash, culture clash. And I do agree with George, though. I think that the reason, I mean, in many ways they were ahead of their time, and I think the issue now is that the financial crisis is going to drive more towards capitated type payment models. And then there are a lot of people that will be running as fast as they can to understand how to be like Kaiser. And I think I do sense that that's an area. I mean, I'm talking now to places in Mississippi and in Iowa, as well as northern New England, who are all moving towards some version of a capitated model. And the reason is they can't. The business as usual is no longer acceptable. And I think what's also changed differently now is that for many of the providers, they actually don't like what they're doing very much either under the current model.
Yes.
And so under a model where the only way you can quote unquote control costs is by reducing the per procedure price, the providers do something naturally, which is they do more procedures. At some point, that running gets too hard. And I think then that actually makes people think differently about this concept of a capitated type model, whether it's, even people are even using the word now, which they weren't allowed to 10 years ago.
Right. Exactly. And a quick comment on that. When you're prepaid, as we are, and you get the money up front, then you can re-engineer care,
right.
and you can do things that make sense.
Yep.
When you're paid entirely by the piece, when you live off a fee schedule, then the only thing you can do is the stuff that's on that fee schedule.
Yep.
And so they're trapped. Providers are trapped in the fee schedule. It's a rigid fee schedule. Medical homes make a difference in the world because you could re-engineer care in a medical home because they liberate the nurse from the fee schedule and they let the nurse get on the phone and make a call. That would be fraud. That would be literally criminal fraud if that was done in any setting outside the medical home. So we've criminalized certain levels of innovation under the fee schedule model. And so we've trapped the current care system who lives in that cash flow in that model. But we're liberating it. So the ACOs and the medical homes are all now moving more toward buying care by the package and not by the piece. And that is incredibly liberating, and providers can re-engineer care and pieces of care when you have that kind of cash flow.
Our experience when we built from the street up healthcare was that medical home type team-based model is what grows in the wild.
Yeah.
That the preference for providers is to work in teams. The preference is to work at the top if you're licensed, to think population-based. And we had the luxury of it because we were not trapped in the fee schedule based upon either, the resources were philanthropy and then a $100 million grant that didn't have the strings attached. When the waiver came into being, which had the fee schedule associated, it was palpable, the changes in the medical home infrastructure, and a refocus on volume-based, production-based care for those providers so they could make ends meet. And the innovation began to change. I mean, our Beacon project might be able to talk about it, but that happened in the middle of Beacon, and the attention to innovation and re-engineering care that we needed for that Beacon to be successful started to shrink. Once we changed the payment again, though, they began to come back to the table.
Fee schedules cripple innovation and absolutely stifle any kind of enhancement because they starve it. Yeah.
So we've got sort of this prepayment idea, and then we have the fee-for-service. Now, you talked about some capitated models. Could you just describe briefly the different kinds that you're seeing? Because not all of them, I'm guessing, are pay-for-value, correct?
Yeah. So I think right now, that in my mind, at least not my mind, my opinion, I'll say, is that I think we're at the very beginning of pay-for-value from that standpoint. But I do think that what are different about the new models are that there are some fairly strong focus on the other two legs of the triple aim from the older versions of capitated models. And I'm distinguishing that. I mean, that's a distinguishing from Kaiser's model, which has been very focused on health from the beginning. But if you look at the 90s version of capitation, it was very much about managing costs, and there were very rudimentary aspects of health.
Yes.
I think the part that makes me worry right now, honestly, is that the ACO models that are currently involved are really very baby steps towards prepayment type models and value-based models. And so they're still paid, physicians are still paid under fee-for-service, and then there's the shared savings at the end if you do well. I actually didn't on purpose. I mean, I call it, the real word is tragedy of the commons. It's actually tragedy of the greens is the way I think about it, because the question is, do you want to eat and kill what you can now and hope that, or do you want to try to be conservative and hope there's something at the end? I think you have to have a very focused and mission organization who's willing to do the right thing, even under the ACO model, because there's still a temptation to do more under the current payment model.
And the other thing about the ACO model, Medicare Advantage is a prepayment model. And you can do all kinds of great things with that prepayment model. And one of the things that was fascinating when the 5-star program went into place, we love the 5 stars, by the way, because we do really well. But the thing that's really interesting about the 5 stars is NCQA had the greatest improvement in the quality of care in the history of NCQA. And lives are being saved. When they put the 5 stars in, care improved across the spectrum.
It's a rising tide.
It's the only country in the world that actually paid more for quality and actually measurably got better quality.
Yeah,
it's an amazing approach.
Yeah, exciting. Did we answer your question, Larry? Yes. All right. Oh, he's tweeting as we speak. Over here.
Hi, I'm Nora Super from ONC. I'm not sure if I'm allowed to ask a question, but I'm going to. So
I don't know, guys. Do we want to vote? Go ahead,
no
Nora.
one else
Thank
is at
you.
the mic.
I really more wanted to, I'm a New Orleans native, so I wanted to thank you, Dr. DeSalvo, for all your hard work on behalf of my city. And also just was struck by, my dad was actually the chief of psychiatry at Charity Hospital for 30 years. So I follow with a lot of grief and anxiety what's happened to the mental health world down in Louisiana. And as you all were speaking, I just asked the panel, and I think about the underserved populations in health IT and patients, and often we're asked that at ONC. What about people who don't have resources? If they don't have computers, I used to also work at ARP, and we heard that about older consumers. They might not know how to use this technology. So, I have my answers to that, but I'd wonder how you all respond to those issues as people that, think a lot about the vision and the future of this field and how we engage some of our most vulnerable populations.
Mental health is absolutely a challenge for us, and we have had a real dramatic change in the kind of infrastructure that's available to the population who was served by what we called the third floor at Charity Hospital. Honestly, much of the change has been really progressive and good in the state. It's been a movement towards community-based services that can help even the most marginalized populations, those with mental health issues who touch the criminal justice system. We have gaps in a number of areas, particularly for kids and for folks who are duly diagnosed with mental health and substance abuse. I could spend an hour talking about it, but I won't. What I will say vis-a-vis this conference is, and my remarks, when I talked about primary care development, I was cheating just a little because those points of care actually include mental health as well. And in fact, if you ask all the providers the type of care that they provide, mental health is the most common type of care provided in the primary care and mental health infrastructure that has evolved since the last 7 years. We have done quite a bit with integrating mental health services into the primary care setting, is what I'm saying. And we were able to innovate and do that when we were paid without being tied to the fee schedule. Yep. That has now changed since we have been tied. And so we are using special funds that we received because of a recent tragedy, the BP oil spill, as well as some other funds. We're using that as a community to try to reinstitute mental health embedded in primary care. That takes care of a part of the continuum. It's such a critical part of great care to be able to. So what we had done, for example, in many of the clinics, including my own, was there was an automatic screen when you hit the door. How old are you? And here's your 2-item screener about whether or not we think you're depressed or PTSD, because it was so prevalent. And immediately longer item if you were flagged, and then embedded in the clinic in a warm handoff available for social workers and other psychologists who could do real therapy or real assessments. And in fact, in our medical homes, we had med psych duly trained providers as the head of the mental health team who were doing both primary care and mental health in the setting and able to talk to both sides. So we've done some really nice models in that community, but it is inhibited when you get to payment. But using IT to mass screen definitely helps increase awareness. Those outpatient providers have also been somewhat advanced in using electronic health records. Those systems are not terrific, and they don't always work great because of privacy issues. So there's some really relevant challenges that we have to sort out, and every community's been working on that. So we are trying to not only make sure we recognize it when it's not known, but in the system that takes care of those with severe mental illness. Specifically, what's happening is that our new managed behavioral health provider has a platform of data that they're encouraging all their providers to use so they can be a single point of entry for data. That's going to communicate with our beacon locally, and it's talking statewide with our health information exchange so that all that information will come in a protected fashion so that we can follow people through the system. But for me as health commissioner, it's pretty critical, obviously, because not only are we missing mental health and primary care, but as you all know, folks with severe mental illness are less likely to get primary care, more likely to die as a result of it. And so we don't want to miss those missed opportunities for care in that population.
I think the empiric evidence, of this new models that we're going to is fairly weak, but we actually wrote a paper earlier in the fall that looked at the physician group practice demonstration project, and we looked at sort of where was the care improved and where was the inappropriate care reduced, the health improved, and inappropriate care reduced. And the good story from that standpoint actually was the biggest area where there was the most improvement was in the dually eligible population. And this was an area that population that people were quite worried about this new model, what would happen to that group. And I'm also very optimistic in the standpoint of, again, payment models are not sufficient, but they are definitely necessary for moving us into this more innovative model. Yep. And the nice part about these new models is that all of a sudden you are accountable for all the care of the population. And so the dichotomy that has occurred for a whole variety of reasons between the mental health care system and the non-mental health care system doesn't make business sense anymore.
Exactly.
So people are now starting to innovate in a much more aggressive way and to try to address that. It doesn't mean that there won't still be gaps. That's clearly going to be, we've been in a bad place for a long time. It's going to take a long time to get there. But I am very optimistic about that, helping address that and pushing people to innovate around that area.
This is just a really important point when we think about this illness model that we've had for so many years and going to what I'll call more of a wellness model, where you actually are a partner with your provider, and it's about what you can do together to make sure that your life is good, rather than thinking about those sick times and going to visit somebody during those sick times. And it's a culture change. And the payment model is just helping us get where we know we need to go. So those were really good comments. Okay, over here.
Hi, I'm Stephen Palmer. I'm the State Health IT Coordinator in Texas. I'm really appreciate your comments on the movement toward accountable care and the miscellaneous variations thereof, and particularly kind of fully capitated and so on. But I wonder a little bit about how generalizable each of your stories is to the broader world where the rest of us are having to deal with those 2.8 trillion reasons why it's hard to do. We heard about a situation with pretty cooperative, or providers with a history of cooperation, not that much direct competition, and kind of a greenfield opportunity where the local healthcare economy was wiped out, and then an organization with a 65, 70-year history of evolving into this space. But the rest of us are competing against this ensconced set of economic dynamics, and I would be interested to hear your thoughts as to how we get from here to there.
Okay, next question. No, this is tough.
The answer is, I think, in lots of failed experiments and some successful experiments. I think the issue here is that it is a huge economy built, and people are optimized under that economy. But it's an economy that, who knows, whether we fall off the fiscal cliff or we glide into one and then are resurrected back. No matter which way you cut it, business as usual is not going to continue, either from a funding standpoint, from the public sector, and quite honestly, from a private sector. It's clear. If you listen to the CEOs and they're talking about the issues, and now they're actually saying it's okay to raise taxes a little bit. Right underneath that, they talk about our biggest worries are healthcare costs and the infrastructure that we need to be able to make this a viable economy. And they say we want to stop talking about taxes and get on to what we really need to talk about from the other side. So I actually think, again, coming back to this issue, that dollars are not sufficient, but they are definitely necessary. And out of the crisis that we're facing, just like New Orleans got to reinvent themselves from a healthcare environment after Katrina, which I'm not saying we should have a Katrina across the country, but we are going to have a Katrina-like event from a financial standpoint. And I am, again, coming back to this, optimistic, is that old world values, old ensconced traditions change when it's necessary. And it won't all be successful, and there will be failures. But I think out of this will come a much better environment for us to live and be people.
And the magic is to buy care by the package and not by the piece. If you want to escape the piecework, total disincentives and dysfunctionality, you really need caregivers who can sell care by the package. When heart transplants flipped from being a pile of pieces to being a package, the price went from about $300,000 down to about $150,000, and the caregivers actually made money at $150,000 because it re-engineered every piece of care. They stopped duplicate tests, they stopped unnecessary admissions. They basically went through a complete re-engineering because the care was purchased as a package. And care sites all over the country can do that kind of re-engineering as soon as they're paid by the package, and they could count on that package as their cash flow. And it has to be a dependable cash flow, because you can't re-engineer around something you can't count on.
Right.
Mm-hmm.
But if you can count on it, you can then re-engineer around it, and you can make huge improvements in care delivery. And the caregivers of this country have more than enough creativity to nail that entirely. I mean, eye surgery, LASIK eye surgery, went from $3,000 an eye down to $2,000, down to $1,000. And they re-engineered the process. The care got better because it was sold as a package and not by the piece. So we need to get there. And ideally, a package that pays you for taking care of a population. So you can take the entire population and figure out how much mental health do they need here? What do they need for nursing care? If you can manage the care around the total needs of the patient, you can do some really smart things in re-engineering. Mm-hmm. So it is essential to change the cash flow and to get the cash flow into various kinds of package purchasing. And I think we were experimenting with various approaches, and I think that's not a bad idea to do the experimentation. But I think we need to understand that we can't get there unless we do that.
Yep.
And it does actually sound like a combination. You know, the changes in the way we're paid will drive the way we deliver care, but we got to change the way we deliver care in order to get paid differently too. It's this
and it's a
chicken
total
and
package.
egg, if you will.
I mean, we do about 12 million e-visits at Kaiser Permanente, where it's a complete doctor visits done electronically that would have been in the doctor's office.
Yeah.
About 12 million a year, and if we would have lost fees for all of those, we would have been less likely to do them.
To do it.
Can I re-ask the gentleman from Texas's question, being from his neighbor Louisiana, and perhaps I may have not understood entirely, but my version of that would be, what have you learned that we should just skip right over as we move to being where you are? Because clearly there have been some failures all over the country, and if we could sort that out, it would be really helpful.
Yeah.
That'll be a long talk, Karen.
All right.
But I do think that integrated models are going to come in, and so I think vertical and horizontal integration is a key aspect of success, both because you need to innovate together, but also because you need a stable base from a financing standpoint to do that. I think the quid pro quo is I think people are worried about price competition if you do that. Mm-hmm. And I'll say it here, and I guess it's wherever else. I mean, I think you can't have your cake and eat it too and everything. And so if you do want to move towards vertical integration, you also have to be willing to have that hard conversation about what is the right how much are we going to spend in healthcare, and what's the regulatory environment to keep us in line with that. Mm-hmm. There are areas that are going to have a hard time, though, getting in this area. I mean, I am my father's son. Minneapolis and northern New England, some areas of the Bay of California are going to have a much easier time than are Miami, New York, and other areas which have built an incredible infrastructure and have invested a lot of money on fee-for-service. And that, everything from the bonds that they're paying under the predicate that they're going to continue under that business model to the way the physicians are organized, it's going to be it is going to be
challenging,
ugly.
I think, David, there is somebody over there who is waiting longer, because this is our last question. Sorry, guys.
You can both ask, and then we'll answer.
Okay, quick, go.
Okay. Thanks, Judy. David Lobach. I'm with the Southern Piedmont Beacon Community, as well as a practitioner of endocrinology at Duke University. And I'm very intrigued by the concept of different sites for delivery care, and it's what I see as on the landscape in the future. And I guess the questions are, when will we be into that new model with the different sites? I know we are in part, and what percentage of care will be at the different sites? And then the real question I have is, are we missing the opportunity of skating where the puck is going to be by spending all these resources on systems, like technology systems that support hospitals and clinics when the majority of the care may be happening elsewhere. And I'm just wondering what your thoughts are on how we're investing in technology and where we might need to be looking with technology in the future. I'm about a 6-month meaningful user of an Epic system at Duke, and it just seems like it does one thing well, but is incredibly inflexible for other types of care. I'd like to hear your thoughts on where we're headed.
I think that's to you with the sites of care.
Yes,
and we just want 4 numbers.
For
Site 1, what percent? Site 2, what percent? I'm just teasing.
no.
But keep it short.
Quick answer. The 4 sites of care are going to happen whether we want them to happen or not. I think there's just a natural evolution. The toolkit is so good for in-home connectivity. The internet apps are so rich and are growing so quickly that we're going to see those sites of care. The challenge is going to be, can we optimize them? Can we use them in the ways that really work for patient care, or is it just another level? Electronic silos are just as dysfunctional as paper silos and physical silos. And so what we need is coordinated care that's patient-focused. And we need to focus the care delivery system and the cash flow for care around the patient, not around the pieces of care. And having said that, I think the answers about where do you invest in what part will evolve from that and can't be answered today. But I think the distributed model of care is definitely going to come, and you should be thinking about that as you make your investment decisions.
It just seems like our current technology is very centered on the hospital and the clinic.
Yeah.
Totally.
And not very flexible
But
for anything else.
there's a device right now, costs $40, you can attach on your iPhone and does a really good EKG. And you can have it done anywhere. I've held it, I've watched it done, $40, and that's going to make EKGs available anywhere. There's other monitoring devices that are just like that. They're going to be available all over in your home and other sites. And so the technology is changing very quickly, and things that used to cost us $100,000 or millions are now being done as apps. Stunning.
All right. I hope you agree that we didn't disappoint here in this last panel. And please join me in thanking them for this fabulous discussion. Thank you.